Good afternoon. This is Erin with the Department of Medicaid. It's not quite 2 o'clock and we are still clear in the waiting room. So we'll give it just a second before we get started.
Thank you very much, Erin. Let's see, who do we have? We have Val. And it looks like, is that Eddie Reynolds, I think?
Yes, it is.
Oh, great. And who else do we have on among our?
Mike.
Mike. All right. Thank you, Mike. I know Steve was going to be on. In fact, I don't think I heard from anybody that they weren't going to be on. So let's give everybody a chance.
I saw Steve logging in, so he should be here. And Mary, excuse me, Mary is currently logging in.
Okay, great. So,
Okay. The waiting room is cleared.
okay.
I think
Yeah.
I see everybody except TJ.
Yeah. And I was just on an email with him, so I'm assuming that he's going to be on. I see the commissioner is on. Hello, Commissioner. We're delighted to have you. Always
Hello,
glad to
Dr.
have your staff as well, but always glad to have the top dog.
Well, hello, Dr. Schuster. I wanted to pop on. I'm going to try to make, more of an effort to join all of these TAC meetings because I think they're just really important. And I do have a couple of things that I'd like to announce this one. I'm not sure if I'm going to be able to stay on for the whole meeting, but I do have a couple of things that I think are good news.
We will gerrymander the agenda to give you time right here at the beginning. And I also want to tell the TAC something from my perspective as the MAC chair. So let's go on and call the meeting to order. I think we're at a minute or two past 1 or 2. So if you're on this flight, you're headed to the BH TAC meeting. So I hope you've all gotten onto the right flight. And let's see. Let's have some of our voting members identify themselves. Mike, I see you first.
Hi, everybody. Mike Berry, People Advocating Recovery.
Great, thank you. And Val?
Valerie Mudd, NAMI Lexington, National Alliance on Mental Illness and Participation Station, representing the consumer voice.
Wonderful. And Eddie?
Eddie Reynolds with the Brain Injury Alliance of Kentucky.
Wonderful. And Steve Shannon?
Steve Shannon with CARP.
All right. And Mary?
Mary Haas with the Brain Injury Association of America, Kentucky chapter.
Great. And let's see, is TJ on?
I am.
Oh, great. Oh, I'm sorry. There you are. And TJ, would you introduce yourself, please?
TJ Littifig, NAMI, Kentucky.
Wonderful. And I'm Sheila Schuster, representing the Kentucky Mental Health Coalition. So we're 7 for 7. That's great. And let's approve the minutes of our November 15th meeting. I sent those out to everyone, but I need a motion from one of our voting members to approve the minutes.
Mary
So
Haas.
moved, Shannon.
My gosh, we got everybody. Mary, I heard you. And Steve,
I'll let Steve motion and I'll second. How's that?
all right, that's great. So Steve motions and Mary seconds. Any additions, corrections, omissions, revisions? All right, if not, then all those in favor of approving the minutes as distributed signify by saying aye.
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 Great, and opposed, like sign, and abstentions. All right, since we have Commissioner Lisa Lee from the Kentucky Department for Medicaid Services on, we would love to welcome you, Commissioner Lee, and give you the floor.
Thank you, Dr. Schuster. I'm glad to be here. I just wanted to provide a few updates and pass along something that I think, so a couple items that I think are really good news for the department. First of all, our unwinding numbers are at about 1.5 million. It's actually 1,558,000 and some. That's still over 200,000 more than we had at the beginning of the public health emergency. And just, remind everybody that our unwinding will go through May. We're working really hard to make sure that everyone that is eligible for the program remains in the program. That's both Medicaid and CHIP. A couple of things that I think just want to brag about a little bit. We started 2024 with 0 state plan amendments pending with CMS. In 2023, Aaron Bickers and Kelly Sheets submitted over about 20 state plan amendments to CMS. And the team worked really closely with CMS so that when we submitted all of those state plan amendments, they were pretty much complete, accurate. And we had in 2023 20 state plan amendments, 20 Medicaid state plan amendments approved, 2 CHIP state plan amendments, 4 directed payment, I guess, preprints that we send to CMS. And that doesn't include all of the hard work that the behavioral health team has done on the 1115 waiver for incarcerated. Also doesn't include, Pam Smith and her team redoing all of our 1115 waivers to submit to CMS so that we can continue to provide those payments that we were paying during the public health emergency under Appendix K. Those providers get to continue to receive those enhanced payments because of Pam Smith and her team's hard work. Later last year in 2023, CMS actually had a site visit on site with Medicaid. They came in person. We had a really good meeting, and a couple of weeks ago, we received an email from CMS asking us, they were so impressed with some of the work we've been doing around our behavioral health initiatives that they requested that Leslie Hoffman and her team come and co-present with CMS at a quality conference that is coming up in Baltimore, Maryland in April. So we think that's quite an honor to be requested to co-present with CMS. And also, the department has been collaborating, having this big umbrella agency is great. We've been collaborating with the Department for Behavioral Health and Developmental and Intellectual Disabilities, the Department for Community-Based Services, and have, through the Department for Behavioral Health, submitted an application to be considered for a children's health, I think they're calling it a policy lab. And only 6 states were selected. So Kentucky is one of 6 states that were selected for this policy lab. And so the intent of this lab is just to kind of help create conversations among state agencies and other stakeholders related to improving outcomes for children and youth with complex behavioral health needs. So we are going to be working with agencies such as the Annie B. Casey Foundation, the Casey Family Programs, the National Association of State Mental Health Program Directors, and the National Association of Medicaid Directors, and the Child Welfare League of America to have those dialogues, see what we can learn from each other, and make sure that we can implement policies to improve the health status of our youth and children with behavioral health needs. So we find that is pretty exciting because, as you know, I'm sure many of you all have seen, and some of the previous legislative meetings and the newspapers about the concern about some of our children who don't have proper placements, those children with high acuity needs, high complex needs. So that is going to be a focus of the department and the cabinet as a whole going forward, is how do we improve our continuum of care for those children with those complex behavioral health needs. So we're very excited about that opportunity and being one of 6 states selected to participate in that learning lab. So just wanted to pass that along and see if you have any questions about anything I think that's some good news.
Yeah. Will there be, will this learning lab around the high acuity kids have any working synergy with the work that you all have been doing on possibly new waivers for complex need kids? I know they're not all behavioral health needs, but certainly some of them have behavioral health needs.
I'm certain that that'll be in the conversations related to what we're doing and what we would hope to gain and see. But I think this learning collaborative is definitely going to focus on maybe mapping out what we have right now, like creating a roadmap related to governance, financing, and our service array, so that we can see where those gaps are and how do we how do we improve it. And I'm sure that this initial meeting is going to just get us all started on that conversations, and it's going to be a conversation that we'll bring back to the stakeholders, particularly this group. I think is going to be really important to have input into that learning lab and what we're seeing and what we're learning and what we're thinking about. I think that this forum, particularly the behavioral health tech, is going to play a very important role in that learning lab going forward.
Yes, I love hearing that, because I think you've got lots of expertise, not only with your voting members, but we always, I see we have 94 people on, we always gather. My theory is you can't pitch a tent that's big enough to get everybody under it that needs to be working on these issues. So we have lots of great participation from different agencies and provider groups and so forth. I see Laurie Grimes is on, who's a pediatric psychologist working with the Kentucky Psychological Association. Steve and the Comp Care Centers have their children's services directors who really have their finger on the pulse of what's going on in the so forth. So I think we have lots to bring to that discussion. I love that.
Yeah, and we do have that focus on the Chennesee Marcy Put Children's TAC too, of course. Yes.
Yeah.
And I know that we've talked about we did so much in 2023. I was going down, I had a list, I think Dr. Schuster at one of the Kentucky Voices for Health, their annual meeting,
yeah.
we went through. And I'm not sure if everyone, and if we've made a big announcement or splash about the combination of our CHIP separate program with their Medicaid expansion program for children. And I think that's important to kind of keep in mind too when we talk about children's health, particularly, is that prior to us combining those two programs, we had a totally separate CHIP program that had a different benefit package. Children who were considered separate CHIP did not get non-emergency medical transportation, nor did they get the EPSDT expanded benefit. So when we combined those two programs, all children now in Medicaid and CHIP have access to the exact same services. Particularly non-emergency transportation, and that EPSDT benefit is really critical because school-based services fall up under that EPSDT benefit. So now all children have access to all of the same services, and it was absolutely transparent to our members, to our children, and to mostly the providers. So that was I think a really big win for our children also. And again, the expansion or the continuous eligibility for children, prior to us implementing continuous eligibility for children could lose benefits if they had a change in circumstance in their families. If their family income changed, they could lose benefits. But now those children have 12 months continuous eligibility regardless of change in circumstance. So that is another big win for the health of our children. So, and then of course the 12 months postpartum coverage. So we've done some really great things in 2023, and I'd be happy, Dr. Schuster, to get the whole list of things together and send out to the TACs. I wanted to do that, over the holidays and Christmas break, and just thank everybody, because we accomplished a lot in 23, but it wasn't just the Department for Medicaid. It was our TACs, it was our MAC, it was all of our stakeholders, our advocacy organizations that help push a lot of these changes through. So I think, want to thank everyone for everything you did in 2023, and look forward to all of the collaboration that we are going to have going forward in 2024 and in the next 4 years. So looking forward to everything we can accomplish.
Well, I think it would be great if you wanted to send the list. In fact, we ought to share it with the MAC meeting 2 weeks from now too, I think, Commissioner. But let's, and Aaron's really good about getting those things out to all of the TACs. But I think it would be helpful to look, it was a great look back when you presented it at the KBH meeting about all that's happened with Medicaid. So appreciate that. Let me open it up to the voting members of the TAC and see if there are any questions for Commissioner Lee, since we have her here.
Steve Shannon, I just want to thank you and your team for the work on the reentry waiver. Expansion of that piece. I think it's going to make a huge difference for people coming out of facilities, correctional facilities, and moving forward. I think it's always been a challenge from years of experience at the local level. People don't have benefits. They don't have a good transition. They kind of get out of jail without a plan. Now they can have a plan, and that's going to hopefully decrease recidivism significantly.
Yeah, we're very excited about that way that 1115, and we were hoping, to hear something real soon and hopefully get that approved. And we're also part of the Department for Medicaid Services, part of the Judicial Commission on Mental Health, and we have routine meetings related to a lot of and I think, Steve, you're on that commission too. And I don't know if you attended one of the last meetings. We had a reentry simulation over at the Administrative Office of the Courts, which I found to be very eye-opening,
Yeah.
very informative. We actually had some inmates who served as I guess they were set up at tables, and they served as, one was, for example, was a jailer, one was a parole officer. And we the participants, we were given a packet, and for example, my packet, I was a female who was reentering society, and I had 4 weeks, and each week was about 20 minutes in the simulation, and in those 20 minutes I had to complete certain tasks. And it was really eye-opening. For example, I had to go have a drug screen, and then I had to see my parole officer. But everywhere I went, I had to have a coin. And if I didn't have that coin, I couldn't get service, because that coin represented transportation. And so it was very eye-opening to see, one table where we had there were housed all of the social services, for example, food stamps, WIC or whatever, your medical card, and the lines were really long in that one area. So it was, to me, it was eye-opening that we have everything all in one area, and sometimes it's very difficult for individuals to receive those services. And then at the end of the simulation, the inmates, kind of told us about their story and how the issues and the barriers that they experienced upon release. And so hopefully that'll help inform our reentry waiver and some of the things that we look at as we go through. But I think that was a very eye-opening experience.
Yeah, it sounds like it. You see all the barriers that we don't think about from 50,000 feet or even 5,000 feet sometimes. So to hear it from people with the lived experience, I'm sure Kelly is well aware of that with the mental health court in Lexington and so forth. So every time somebody has to get someplace, or somebody has to access that next thing, whether it's available or not. Any other questions from any of our voting members?
Sheila, this is Mary Haas. Commissioner Lee was very interested in the Children's Policy Lab. Just recently, over the last month, I've been getting a lot of issues around children with abuse and some gun violence that is related to brain injuries. So I think when you talk about complex needs and everything, kind of keep those children in mind. And I'll be very, very, very interested in what comes out of that. So thank you for your participation.
Hopefully we'll have an update at the next behavioral health TAC related to that lab, because there is an in-person meeting with all 6 states, February, I think 7th, 8th, and 9th. So we should have an update after that.
Our March meeting, we ought to have.
Yeah.
That would be great.
Yeah.
Thank you.
And I think just one other thing that I wanted to I think Dr. Schuster, you and I have talked about this, but I want to make the TAC aware in case there's conversation that needs to be had. We have been approached. The community mental health centers have I think a primary care component of it too. So currently, occupational therapists are allowed to provide services in a CMHC, and we have been approached to allow occupational therapists to provide therapies in a BHSO, for example. So what we are looking at right now and considering is adding a place of service of BHSO into the occupational therapy regulation. That way, I think everything would kind of remain consistent. So I just wanted to give you all a heads up so you could be looking out for that too, and let you know, that way, maybe if this committee needs to have some more conversations on there, if you have questions, can reach out maybe, or have some conversation at the next TAC meeting. But just wanted to let you know that our thought was to just allow that place of service in the occupational therapy regulation.
So they would be providing their OT services in that newer setting as they
Yes.
have been in the
Yeah.
CMHC.
Yes. And that way
Okay.
we're not opening up the behavioral health regulations. We're
Right.
opening up the occupational therapy. So I just wanted to, so that when that came out, this body and this committee was aware of where that's coming from.
Okay, that makes sense. That's something that you and I had talked about, I think, Commissioner, as well. Any other questions for the commissioner?
Just to clarify, I think this is exactly what you just said, but just to clarify that the OTs will still be filing their codes. There won't be any new codes like behavioral health codes that they can now use. It'll just simply be the place of service that changes.
Correct. And then I'm assuming that if a BHSO wanted to hire an occupational therapy therapist and bill for that therapist, they could hire that therapist and bill for those occupational therapy codes.
Thank you.
Yeah, I think that keeps everything kind of in its lane. Appreciate that. And there are, I think, OT needs. We've heard that for people with severe mental illness who have been maybe not doing some of their own tasks of daily living, if you will, if they've been hospitalized a lot or if they've been in the care of their parents or whatever. And we want to get people into housing, and they need some of those OT services and therapies. So thank you. That makes sense. Any other questions? Well, I hope you could stay on for part of our agenda, please, Commissioner. So that's great news. Thank you very much. I sent out the approved meeting calendar for our BH TAC. And so this month and in March, we'll meet at 2 o'clock to accommodate the legislative schedule. And then we'll go back to our regular 1 to 3 meetings. And just to point out that the MAC meetings, which are typically on the last Thursday or the 4th Thursday of the month, we added a half an hour to the time. I'm not sure I can sit 9:30 to 12:30 chairing that, but anyway, we may have to take a break in the middle for a little bathroom stop or something. But we're starting at 9:30 and going to 12:30 because we keep starting at 10 and then running over and closer to 1. So, and I'll send out that reminder. I also want to point out, and I think we give, I'm probably biased here because I usually give the reports, but we give a very detailed report of the TAC meeting at the MAC, not just when we have a recommendation, but I let the MAC members know. The MAC is the Medicaid Advisory Council. I let them know the topics that we've been talking about, what we've been asking for from Medicaid, what we've heard from providers and family members and consumers and so forth. Typically, the MAC reports or the TAC reports have been very hurried because they've been at the end of our long agenda. And usually it's just we met, we don't have any recommendations, or we didn't meet, or we, met and here's our recommendation. And I'm going to reach out to all of the TACs and encourage them to let us know what kinds of topics they're looking at, what kinds of questions they've had. Some of them have requested, for instance, data from the MCOs. We've done that in the past, not recently, but I think it would be helpful to the MAC members to get a much better idea about what the TACs are doing. So we'll have an opportunity to do that. And I think it's a good way to look at the enormity of Medicaid, actually, because if you don't hear from, home health, and you don't hear from the therapies, and you don't hear from the physician standpoint and the consumer standpoint, and as Steve has the reentry TAC, you just don't know about those things. And there are a lot of people that represent various constituencies on the MAC and don't have that information. So I encourage you all to tune in to the MAC meetings. They're on Zoom and they also post the recording afterwards. But we get an update from the commissioner and from Medicaid, and then we have a series of things. For instance, at our January meeting, we will be getting an update on maternal and child health, which is something that we ask for twice a year. And also, and Mary, you would be interested in this, there's going to be an update on PDS from Pam Smith. That's something that Eric Wright, who's a member of the MAC, has been asking for. So those are the kinds of things. I think in future meetings, we're going to be looking at language access. We had quite a discussion in November. And actually, we've not tackled that here in the BH-TAC, but there are a lot of providers that are not following the rules and providing language access to people for whom English is not their first language. And of course, it's a particular problem in the behavioral health sphere. So we're trying to engage various providers and various MCOs about what they're offering. Transportation is another issue that we need to be looking at. So some of these things that go across all parts of Medicaid. Let me ask Pam Smith to give us a status update on the 1915I SMI. I still call it a waiver. It's really a SPA or a state plan amendment. And we had the town hall meetings. And Pam, are you on?
I am.
Oh,
I'm
okay,
here,
there
and
you
I
are.
am honestly here. I will turn on my camera for 1 second just to say, if it's even working, just to say hello.
Yeah.
But I've got stuff spread out across all 3 screens, so you would be looking at the side of my head. So I'm going to turn it off while I do the updates because I've got so much exciting stuff to share about the 1915I. So we had our 5 town halls in December. So we did those from December the 6th through the 14th. 2 virtual sessions. The webinar or the slide deck and the recording has been posted to the website. So I'm going to, in the chat, I am going to put the link to the page. And if you scroll, it's the Behavioral Health Initiatives page. So if you scroll midways down, you'll see the specific updates about the 1915I. We are in the process of reviewing the FAQs, so all of the additional questions we collected during the town hall. So those will be posted very soon. I just looked at the formatting today, and we changed a couple of things so that we're going to highlight what's new or what's an updated answer and updated information, so it'll be easier to tell what has changed with those. Most exciting part is I have the draft right now. We are internally reviewing the full draft of the SPA as it is completed, that will go out for public comment. So we are doing our last review prior to public comment. And we are targeting it to go out for public comment. And I just see no reason that we will not hit this date for January the 29th. We will leave it up. We're going to, because of leap year and just that, that extra day kind of throws people sometimes. So we're actually going to leave it up an extra day in there. We're going to leave it up through the end of February the 29th. We are working on a companion document that we will share, and probably will also record a webinar that will be a guide. The SPA itself, I believe, is 70-ish pages long. And if you've looked at any of those before, or you've looked at the 1915 waiver applications, it's a CMS format. Sometimes it can be really hard to know if you're looking for something specific, where do I want to look to get that, or where do I need to see that? So we're working on supplemental documents that will go out along with when that gets posted for public comment. We're going to send out a reminder about a week before we post it, as well as we'll do the announcement when we post it, and then we'll do the follow-up with people as we monitor as public comments are coming in, but we'll make sure we follow up and remind people about at the halfway mark, and then about when we get down to about a week left. We are targeting a very quick turnaround time for our review and any modifications, and hoping to have everything submitted to CMS in March for their review. So super excited about SMI. I think our the town halls, we got to talk to a lot of family members, advocate groups. I think they were very successful. We got a lot of good questions, a lot of good information. And just, as a reminder, we've collected all of that information that we had, as well as all of the, any comments we've received to date, as well as what we received through formal public comment. We are using all of that to inform what we do with the state plan amendment, and to make sure that, our first draft of this really, that we're serving as many people as we can, with, the best services that we can. So I think it's so exciting. And, again, I'll encourage you all to encourage people to watch for it to come out, to make comments on it, and, to really, give us that information, because we do use it. We read every single one of them, and we will put out a response to the public comments following, once that public comment period is over, so that everybody will get a response to their public comment.
Great. And that's pretty much what you had anticipated. I think, Pam, was that you would have that SPA ready for public comment, hopefully by the end of January. It looks like that's what you're aiming for.
It is. I think we're right on track.
Yeah. Let me open it up, and I'm going to open it up to anybody who's on, because this has been a topic that has been of such interest. Some of us have been working on this for 20 years or so. So let me open it up and see if there are any questions for Pam at this point. Of course, we're all, waiting. I will say, Pam, that I found the process a little bit difficult, because it required, of course, written questions to be submitted at the town hall meetings. And I think there were people that came that assumed that it was going to be verbal and so forth. So I don't know if that affected participation or not. I do think that your team, at least the one that I monitored online and then the one that I attended in person, it looked like all of the questions that were submitted or responded to during that meeting. Now, sometimes the response was, we'll take that back to the team and see where we go with it. So I guess I'm asking, when the FAQ comes out, will those kinds of responses that you all arrived at be there in response to some of those questions?
Yes, they are. The only thing you will not see in the FAQ is if it was very specific to a person, and those we address with the actual individuals. But we tried to, though, still, even those, tie them to a larger question, to make sure that it still was, that information was addressed. But we also have talked to those individual people that brought out, just those very specific scenarios. But yes, it is. I think the page, I'm trying to think, it's about 15 pages, 13 or 15 pages long now. We added a lot of information with these FAQs, and we, the doing the submitting the question in writing, or using the online, that was the first time we had rolled out using the QR code, where you could actually submit, type the question in. It was very different, but I think it allowed us to make sure that those questions, that we captured specifically what the person was saying, and avoided some of, maybe the translation or, misunderstanding of some of them. So I think it's something that's going to require finessing, and that we'll all get better at and get used to, how do we do that, and what the best way is to handle those questions, to make sure that everybody feels like they do get to participate, and that their feedback is heard, and that their questions get answered. But I do know we had a lot of really great conversations even after the meeting. I know there was significant time after the meeting where there was lots of good conversations that happened. I know Dr. Schuster, the one that you were in, really enjoyed the family that we got to speak with, and I know that we were able to address a couple other questions and concerns that they were having. So it was good to be able to do that too, even outside of what we were there for. We were able to help them and get them in contact with some people to address some other issues.
Pam, this is Leslie. Dr. Schuster, I was just going to mention what Pam was saying about the Louisville, especially the Louisville area, but I think we had at least 3 of the town halls that we had individual families in some pretty dire situations coming up to us. We talked to them afterwards, and to me personally, that was what made it worthwhile. Like, we literally helped those families then, like right then, right? And so that personally made it feel like that all this was definitely worth it. Helping, even one family during those sessions, I think was like a wonderful opportunity. Thanks, Pam.
Yeah, the only suggestion I would make is that the family that came there at my invitation that I've been working with really was in a dire situation. And I had said to them, I don't think that you will have an opportunity to speak, but I don't know, because I hadn't been to one yet. And if I had not spoken up on their behalf, they would not have told their story. So I guess my suggestion to you, when the formal part of the presentation is done, would be to ask if there's anybody in the audience that would like to speak at that point. That would be my suggestion, because if I had not been there, I think Leslie to have said, here's somebody that I know and has a situation, and I think you all would benefit from hearing about it. Because I think families and consumers are very reluctant sometimes to know when it's appropriate or is okay to speak up and so forth. So that would be the only change that I would suggest. Would have been really helpful.
I like that. I think that's a very valuable suggestion, because I think any of you all that have worked with me very much know I have a phrase that I talk about all the time about, the why behind why we, what we do. And so I think that it is so important, because the program, it's for the participants, and they're the reason that we're here, and they're the reason, them and their families, are why we do what we do. So that's a critical, it's paramount to hear those stories and to understand that and to give that opportunity. So I take that as a very valuable feedback, and we'll share that as we go forward.
Yeah, thank you. Any other questions from anybody who's on? I'm looking at Kathy's picture, Kathy Dobbins, because you've asked in the past, Kathy, about respite. And I don't know whether you attended any of these meetings or submitted that question. I think you were curious about how the respite benefit would work. Is that right? Do I remember that?
No, I don't remember that respite being a particular area that I was concerned about. I did attend the Louisville meeting, but unfortunately I had to squeeze it in between a couple of other meetings, and I did it virtually. I think, my questions had to do more with the, the narrowing down of the funnel and eligibility issues, and also, the hospital requirement that we talked some about, and I think the homelessness piece was fairly clear. I wasn't 100% clear about provider eligibility either. I think it was addressed, I think in the meeting, but in reading reading the bill, or the whatever you want to call it, it sounded like people who were already receiving supportive housing might not be eligible to receive this benefit, and that raised a concern for me, because some of those are individuals who met the Olmstead definition, who had many hospitalizations and institutionalizations, arrests, et cetera, and Just wanted to be clear about eligibility for those individuals. So those are some of the just, top of mind concerns.
All right. Thank you. And I'm hoping that they will be addressed in the FAQ.
They are. There are several questions specifically around actually all of those topics. So
Okay.
hopefully it will, I believe that we have sufficiently addressed those. But if not, please, Kathy, reach out to us and because we want to make sure that we do. We want to make sure, that it's clear. Sometimes it's easy when you speak it all the time to think you're communicating clearly. And so, I always want people to say, wait a minute, that, step back, walk me through that. So, but we were very intentional about making sure we included several questions about that to try to very clearly articulate that information.
Thank you, Pam.
Anybody else have any other questions? All right. Well, I appreciate that, Pam, and we will certainly be on the lookout, and you'll let us know. I'm assuming that I'll see a cloud of white smoke coming up from Frankfurt.
You
Like
will,
with the
yes, we're gonna,
with
yeah,
the
we're gonna,
election of a pope, right? That we'll have good
we're,
news.
we're looking at renting a plane to do, a banner. Now you'll see the traditional, Kelly Clays will be, on it like she normally is. In fact, she's already got we had our regular work group meeting today. And so, I mean, everybody's got, the calendars. It's like, okay, this is set to go out on this date. And this is so, everything is in place and we have those dates marked and, I cannot tell you how excited and it's been such a team effort and collaboration across the cabinet to get here. So it's been a long time coming and we're very excited to see where we go from here.
Yeah, well, we certainly are excited too. And you had asked if you could go on and do further down on the agenda, folks, at number 9, where it asked Pam for her usual
Yes,
update
thank
on
you.
the 1915C waiting list, and she needs to get off earlier. So let's go to that, Pam. We asked
Okay.
about the waiting list, the update on ABI waivers, access to therapy services. And then Mary had raised an issue about intervention plans from the ABA folks and who could actually do that implementation. So take it away, Pam,
Okay.
if you will. Thank you.
So our current waiting list numbers, as of, and this is, as of the beginning of the week, we have our two waivers that have waiting lists. We have for SCL, the total is now 3393. Future planning has 3307 on it, and urgent is actually down a little bit. It's 86. The behavioral health team has been doing, I know, a lot of work on looking at the individuals who were in that urgent category. We've been looking at who is actually getting services. Right now, we've been reaching out to individuals. So that number has actually, our urgent number has actually decreased, and we do not have anybody waiting for an emergency slot. Michelle P., we are at 8,810 currently. The DDID team, I believe they're allocating at least monthly. We've been talking about the frequency on how often they were sending out slots to balance, having providers onboarding people in the CMHC so that they didn't have, because we were doing it in kind of a bulk, like 250 every 90 days. But that then made all of those, CMHCs then all of a sudden had all of those assessments to complete in a short amount of time. So we, in talking with them, we've modified those, how those allocations have been going out, and we've been doing them more frequently, just a smaller number to allow for the CMHCs to have more time to be able to do the assessments and for providers to be able to onboard individuals without kind of having that delay there. Our HCB waiver, we are approaching a waiting list for that. We do not have a waiting list at this moment. There will be information coming out about that, but we do not have currently for that waiver or any of the other 4 waivers. We do not have a waiting list right now. It's just currently still SCL and Michelle P. the ABI waiver access to therapy services. So there has not been any change to that. The waivers, we cannot remove or change those therapy services from how they currently are today. That cannot be changed until the MOE is up, which that maintenance of effort period will go through when we expend all of the ARPA funds. So that will not be until, into fiscal year, guess it'll be technically it's fiscal year 25. So it will be when we it's in the first half of 2024. So, and we will communicate. I have, talked to the providers to let them know for sure that before we do that, there will be training. There will be, a period of time where we do, at least a 90-day transition so that we help people to, if there's people that need to move to state plan. I will say, looking at some of the numbers and talking to some of the providers, we've had some individuals already move to accessing the services through state plan. And there's not been any problems. So we're just continuing to work with providers as they have questions, but there's not really been any significant change to that or any from where we were. But we will communicate in writing and likely with a webinar with the providers as we get closer to when that actually will change. And as far as the ABA intervention plan requirements, Mary, I may need help from you a little more on context from that, or may ask if you will send me that question and I can kind of go back and be able to talk to the appropriate staff to get the answers to that. So if you don't mind, if you can give me some more information around that, I want to make sure that I'm giving you the right information that you're seeking.
Okay, Pam, I'll be happy to do that. Have you finished the report? May I ask you 2 questions, please?
Yes.
On ABI?
Yes, ma'am.
Okay. On the first thing is, I have been getting some questions on the case management. I know there was some conversation before we had to go through the comp cares. Has any movement been where a family who does want a PDS can use their current ABI case manager?
So we are in the process of, expanding that, and we are certifying providers. As of right now, it's been mostly HCB, and I'm thinking there's been 3 large providers that are in the process right now that have went through the training and that are in the process of becoming certified. I've worked with one SCL provider that expanded out to accept some Michelle P individuals. So I'll talk to Karen to have her talk to the providers. And then if you want to refer anybody to Karen, and we can talk to them and walk them through the process. But yes, we're working on that right now, expanding that out so that PDS case management is a service that any of the case management agencies can provide.
I think that would be very helpful, especially for the population I advocate for. And it's just not that the comp cares haven't done a good job. And, the 7 counties I've worked with, but it's just they have such heavy caseloads, and some of our people are medically fragile and they have a lot of other issues going on. So I think from some of the families I talked to, they would like the PDS, but they just don't feel real comfortable unless they could keep a ABI case manager. But you and I can talk more about that. But I do think that's something that needs to be developed or worked on or whatever. So I welcome, some input on that.
Absolutely. And just, refer those individuals to us. And we're working on providing some additional guides out to both participants and their families and the provider population on really what does it mean when you PDS? What are your responsibilities as the employer, as the participant or their rep? What does that mean? What are you responsible for doing? Really trying to get more education out there to help people understand, what it means, that it doesn't just mean, that a family member can be your caregiver and get paid. It doesn't just mean that, somebody, it gets, a check gets cut from this, financial management agency. It's really, there's a lot of, as the employer, as the participant, you have a lot of responsibilities, and we want to make sure that participants or their representatives understand that and understand the control that they have over their plans and what they can do, so that they feel empowered to do that.
I would like to have a conversation because what I'm seeing is more from some of our younger parents. They really, their kids have been out in the community and they really don't want to go the group home route. They want to be able to keep, some therapies and some things that will keep them up and going and at the top level of their independence as they can be. So I welcome a conversation on that. So, but we can do that on another day and another dollar.
That sounds great, Mary. Dr. Schuster, thank you for letting me go. First, I do need to drop to go to that other meeting, but Alicia is on. I know Leslie's still on, and then as always, I'll put my email. I think everybody has it, but I'll put my email in the chat. If there's anything that comes up that you have questions or you need anything from me, please do not hesitate to reach out. But thank you for letting me go first today.
Yeah, thank you, Pam, and thanks for all the good news, particularly on the SMI front. We appreciate that. So status of the waiver revisions for SUD services to incarcerated persons.
Dr. Schuster, this is Leslie.
Yeah.
I just, if I can, as you can tell, Pam has been very busy, but I always try to give credit to folks too, that I just, we've talked about this. It's been 20 some years in the making to get this 1915I with the companion of the 1115, and all these authorities, a very complex model to meet the needs that have been requested by the Kentucky members and advocacy groups. But this is one of the greatest collaborations I've seen in a long time with, the behavioral health group, with the Department of Behavioral Health, other sister agencies, Pam's group, and even agencies outside of our cabinet. So just really proud of everybody. I'm always proud of my teams that do such good work for the state. So I just wanted to give a shout out to everybody. Jody and Angela are on here too. They've had lots of work related to SMI in general. And also for the SUD services to incarcerated person, just to keep everybody from lack of confusion, because I get a lot of emails related to this. So it is now based on CMS's guidance back in March. It is now the reentry waiver. So it's the same thing as the old incarceration waiver. However, based on their guidance and being able to add in other populations, now it is will be under Team Kentucky. So it's Team Kentucky's 1115 reentry waiver. And I know that's more than what everybody wants to hear, but people will call me and they're like, where's this, where's this incarceration waiver? And I'm like, it's called the reentry now. So I just want to tell you that because I have folks that ask.
Yeah, so you told us that before, and I need
that's
to
okay. It's a lot. It's a lot to remember.
Yeah.
Angela and I have spoken earlier today on the persons returning to society about this waiver. So I'm going to let Angela just go ahead and give her updates from this morning with you as well. So Angela, take over.
Thank you. Thank you. And I guess Steve could give it as well, because he's already heard it, right, Steve?
Right.
Take it away, Angela.
Keep us in check, right?
Right.
So again, we want to appreciate and thank everyone who submitted comments, recommendations, and support to the draft that we had posted for the reentry section 1115 demonstration opportunity. So I think again, the last time that we met, we were moving into the public comment period, or maybe we had just started the public comment period. So we did complete the public comment period in early December, mid-December. We received, I think, a total of 13 letters again in official public comment periods. Again, those included several supports and suggestions and recommendations within those. But again, from various advocacy groups and individuals across the state. So we did review those. following the public comment period, and have posted responses to those comments on the website. And again, we'll drop that into the chat box where that can be viewed. So again, we did provide a summary of all of those comments that we received and responses back to those. There were not any significant changes made to the application. Again, we are certainly considering all of the recommendations. And again, I think we've tried to be very transparent through the process to help everyone be aware that there are many needs, initiatives that we are trying to meet in the demonstration, and based on guidance and research and discussions and considerations, again, feel as though that this is the best approach to move forward, hopefully to receive a more timely approval from CMS. And so again, that we can get that started. So again, as I had mentioned to Steve earlier, not to sound like a broken record, we do intend through our implementation planning process to also parallel think of the opportunities that we can expand settings and populations and services to the waiver as we plan even implementation of hopefully what will be approved. And so with all of that being said, we did submit to CMS our application on the 30th of December. They do have 14 days to review the application for completeness. So hopefully next week we will hear from them. And again, that's not an approval. That's just a check off that the application included everything that it needed. So the next steps from there will be CMS posting that for a federal 30-day public comment period. And then following that 30-day public comment period, they'll begin their official review. And so typically what happens from there is they'll review that. It could be 30 days, 45 days or so. And then they usually come back to us with the first round of questions. We review those, respond, and then that kind of starts the negotiations. And so again, just to remind everyone, even with an approval, the state still does have to then submit the implementation plan, which then has to be approved before we can actually implement and get started. So we hope to kick off with the advisory work group early this year to start and begin the implementation planning process and really get ahead of that, so that hopefully when we get to that approval, the timeline to submit that implementation plan is very short, and then again a short turnaround with CMS to review that. So that's the goal and where we are regarding the reentry application.
The 11-15 Team Kentucky reentry waiver.
That's correct. And so, yes, what we're also, again, just so everybody's aware, we have the extension for our SUD 11-15 demonstration. We have our SMI demonstration and recuperative care components that we submitted last year pending. And then again, the recent submission for the reentry. So in discussions with CMS into the new year, we will work with them and have some talk about how we can hopefully move all of those initiatives together forward, and again, as timely as possible. But our, again, feel in discussions with CMS is that that is the intent, is to work with us on how to do that. So that we kind of really streamline all of those initiatives, because again, they all include implementation plans, monitoring protocols, evaluations, and so forth. And so again, each of those components in demonstration requests will require those things. And so again, it will, I think, be in everyone's best interest to really figure out how to get those on the same page and get those moving.
So, and you may have said this, Angela, is the, you haven't sent it yet to CMS, right?
We did send it to
yeah.
CMS.
Okay.
It was December 30th. Yes.
Okay. So, and is what you sent posted also on the website?
Good question. Sorry, I meant to, that was one thing I did leave out. It should be posted, Dr. Schuster, by the end of the week. We did have to fix some of the web links in the application. So it should be posted. And again, I'll drop in the website, the link to where the responses are, and it will be posted in the same area. You can view it in the same place.
Okay,
Good question.
great.
Thank you.
How did they do, Steve? Since you've heard this.
Very good. Second time today I've heard it, and it's just about the same message each time. Very thorough job by Angela, as always.
Thank you.
And does anyone have any questions for Angela about the reentry? I think Steve has talked about it. He's been chairing this TAC with very little to talk about until recently. So feels good about what this looks like. So did you say you got 13 comments? Was that right?
There were several comments within, yes, but again, I think there were 13 different organizations and individuals.
Organizations that send in things. Okay. And some of them were probably multiple comments, actually.
Correct.
Okay.
Yeah.
Because I was going to say there ought to be more interest in this than 13. So good.
Yes.
Any other questions or comments? I see Dr. Brenzel's on. Do you have any comments about this, Dr. Brenzel? Okay. Thank you.
No,
Glad
just
to have you on.
excited to get on with it. And our behavioral health team apologizes. We had a conflict, but the commissioner directed me to break out and make sure we were represented here. So glad to be here.
Great. Thank you very much. Okay. Well, that's more good news, I think. So we asked last meeting in November about how rates get changed and so forth. And Justin Derringer gave a really great comprehensive kind of run through of that. So I think my question here was, because he said sometimes at the beginning of the year, there's kind of this question about, so I guess my question is, are there any behavioral health rate changes that are under study at this point for 2024?
Dr. Schuster, Leslie Hoffman asked me if I would take this agenda item. My name is Victoria Smith, and I'm a policy analyst in the Office of the Commissioner.
Okay.
We have good news. I know we've looked at this. This has been on your agenda ongoing. ODA has a team of research and data analysts looking into this. We're doing a comprehensive behavioral health.
Yeah.
Research study and analysis. We're looking at every single code on the 2023 behavioral health fee schedule, and we're looking at those codes and their respective modifier combinations are being evaluated. Multi-state comparison is being done. We're looking also not just at other states' fee schedules, but also their regulations behind their fee schedule, so that we can understand limitations or prior authorization requirements, so that we can get as close to apples as we can. You know, Medicaid's different in every state, and so comparing across state lines is sometimes very difficult, but the ODA team is really digging in, and they have several people working on this. It is our intention to wrap up that research by the end of this month. Early next month, we'll be working on doing a presentation for you at the next TAC meeting in March. If you would like to continue to have this on your agenda, we'll have a complete analysis of where the Kentucky behavioral health rates stand in relation to other states around us and across the nation. So I hope that is good news for you. I know, like I said,
I think it's very good. Yeah, very good news. I appreciate that, because this came up in the report we received on the legislation that had asked for this analysis, I think.
Yes.
And then it turned out that the comparisons with the other states was not clear in that report. And I guess it was actually not
limited. There were a few states looked at, but the ODA team has really branched out. They're really looking at every state across the nation that they can find fee schedules and regulations on. And like I said, we're really digging into even limitations of services or prior authorization requirements. ODA is the Office of Data Analytics. I'm sorry, I always feel like everybody knows that, but ODA, the Office of Data Analytics, they're the team of people who are the experts on really digging in and researching some of this stuff. So we are hoping, like I said, our plan is to bring you a presentation. So if you'll leave us on your agenda for the next TAC meeting, we will have
We
a
will
comprehensive
absolutely
report to
do
give
that.
to you.
Victoria, thank you so much for being with us. Nice to meet you.
Nice to
And
meet
that
you,
is,
Dr.
I think, really good news because we have had some questions. We were not really clear on the process, and obviously rates are always an issue. I think for all providers and actually for consumers and family members, because they also often dictate access to services. You know, if you can't get paid enough to do the service, you're not going to do it. And so you're not going to provide it, or you're not going to be a provider or whatever. We have a lot of people that in the behavioral health professions who choose not to be Medicaid providers because of the rates. So Kathy Adams says, is there any update? Oh, I missed it. Kathy, why don't you just say what your question is? Because I couldn't read it fast enough.
I'm sorry, I was just asking if there was any update on the annual fee schedule changes that usually occur in January.
I can't speak to annual changes at this time, but I do know that any changes I think that will happen after this comprehensive study that we're doing. But maybe someone from Ann Holland's team or Leslie, maybe you can answer that question more directly.
I don't think anything's been completed yet. Like, this is still early, and I think it usually takes us a couple of months after that. Unfortunately, I know that's not what everybody wants to hear, but I think was it April last year? Not that we're aiming for April this year. I'm just saying I hope to have that out earlier, so I can follow up on that.
Thank you. It would just be helpful to know whether or not to expect a fee schedule change before this additional information is shared.
Is anybody else on for Medicaid that is aware if we've even received the information yet?
The analysis hasn't even been completed as far as the rate study analysis. It won't be completed until later this month, and then it needs to go to review with your team, Leslie. The behavioral health team will need to review the results of the analysis. So like I said, early February, we're hoping to have that analysis completed and reviewed by your team and the commissioner's office.
Thank you, Victoria.
Yeah.
We'll try to provide an update.
That's really exciting, and we will definitely put you or whoever the folks are, Victoria, that would be making that presentation. We'll put that on the agenda high up because again, rates are always of interest. So thank you very much.
Thank you, Dr. Schuster.
Yeah.
Hey Sheila, this is Bart.
Bart.
I'm driving down the road, so I apologize for the background noise. But if you don't mind, a quick follow up to Kathy's question for clarification, because I think we were convoluting two different issues. I think Kathy's question was on the annual changes that are supposed to be effective 4/1. On just the routine changes related to the Medicare fee schedule connection to the Kentucky Medicaid fee schedule. Are you all going to release those in time for the MCOs to update their systems before 4/1? Or due to this analysis that Angela was talking about, or is that going to all be on hold until that analysis is done? Does that make sense, Leslie, what I'm asking?
Yeah, I think there was some confusion a while ago. I think we still do that annually as far as the new rates in general, where we see what CMS has sent us. And I'm not the person who totally handles that, so I'm sorry, but I think it would be done annually.
Yeah, I think Bart was saying that typically it's done to be effective 4/1, Bart.
Well, generally, historically, it's been effective January 1, but the information doesn't come out until February or March.
And that's what I was talking about, Bart. Yeah.
Right, right. But you all had said you're moving the effective date to April 1, that you can have the information out before it goes into effect. And so that, I think that was my question is that going to stay the same, or given this, I assume that would stay the same, and the results of the analysis that was talked about would be something that would be effective in the future.
So Bart, let me
Potentially.
follow up on that because I don't want to cause any more confusion than I may have already done. So what
Sure.
you were saying is what I was talking about. We usually receive information in general, always, and then do an annual update. We normally don't get that out to April, but now we've got this assessment also that Victoria's been working on. So we want to take that in consideration as well. But let me just follow up and get an answer back out through Aaron, if that's okay.
Sure. Yeah. And Victoria, I just called you Angela. I apologize. I'm driving, so I missed that. My apologies. So, but
That's
okay.
okay.
Thank
I've
you,
been
Leslie.
called worse, so.
Okay. All right. Appreciate
All right.
it.
So Leslie,
Thank you.
you'll send something to Aaron and me, and I'll get it out to everybody.
Yes.
Nina, you have your hand up.
I do. We're talking predominantly now about the BHSO fee schedule, the April 1 thing, but excuse me. I just want to make sure that we also have on the list EPSDT rates. Hospitals have brought that forward to the commissioner, and we are waiting on an answer back on those. So just while you're doing your studies or whatever, if you'll ensure that EPSDT hospital rates, these are for specialty services in a hospital, that those are also evaluated.
And Sherry Staley, are you on? She's been assisting with that.
Yeah,
So
she's,
we'll
well,
get that on.
yeah, she's on.
Okay, thanks.
So I guess I'm confused and I don't know enough about this, so I don't want to confuse things more, but you're talking, Nina, about EPSDT rates. And I guess the question to Victoria is, are those being considered as BH rates that are under this study that you're talking about?
Yeah, and that's my question too.
The behavioral health rate study that we're doing is any behavioral health code that is listed on the current behavioral health fee schedule. So that's what this analysis that I'm involved in is looking at exclusively. So if you look at the behavioral health fee schedule on the DMS website, any code that is listed on the 2023 behavioral health fee schedule, that is what we have ODA analyzing and comparing to other states.
Okay, well then my question is separate from that because I have the
Yes.
BHSO fee schedule from April 1 of last year in front of me. These are rates for specialty services in a hospital, and they were low to begin with, but when the PRTF rates increased to 500 and 600, they are below those rates as well. That's why we brought them up.
Yeah, Nina, this is Veronica Judy Cecil with Medicaid.
Hi, Veronica.
Hi, good to see you all. That is going down a separate path from what Victoria is working on, but it is under review and discussion within the commissioner and some other folks in DMS.
Thanks, Veronica.
You're welcome.
Okay, so your question is answered, Nina, and that's going to be a separate track. And would only apply to the hospitals. Am I right about that?
That's correct.
Okay.
Thank you.
You could, I know we have some hospital folks, typically you, that are on. So when those are ready, if you want that to be on the agenda for the BH TAC, when they're ready, if you want to let me know, we can put it on.
Yeah, well, thanks. Thanks, Sheila.
Because I think what we're looking for in March is the Victoria study. I'm calling it your study,
right?
So you can be the primary author here and not ODA or OTA.
Yeah.
ODA.
You can call it my study, Dr. Schuster. That's okay. Either myself or a member of the ODA team will be presenting it to you in March, but you can call it my study if you want to.
Okay.
Thanks.
Well, you were here to talk to about it, so that's how I'll remember it anyway. So, okay, so we've got that straight now. So the EPSDT hospital rates for specialized services is a separate track, and Nina will let us know when you've heard back, Nina, and we can put it on the agenda. And then Leslie, you're going to let me know the answer to Kathy and Bart's question about the kind of annual updates and how that's being handled relative to
those are all kind of like three pieces. So we'll get those answers back to you.
Okay. Wonderful. No wonder rates are so confusing. I had put on here an update on the use of BH associates, but I have since learned that letters went out to all of the all the relevant licensure boards, and I think the date for those replies from the licensure boards is not until tomorrow, actually. So I'm gonna put this on our March agenda, because I figure at that point, Medicaid will have a whole lot more information. There's no point in kind of surmising what kind of response you got from the, or getting from the licensure board. So.
Right, and we certified those letters, Dr. Schuster, we certified those, so we can tell who's got them and not.
And I think some of us reached out to our boards and said, yes, please respond to this and so forth. So let's put that on the March agenda as to come back to, okay? I think we had asked Justin last time about what kind of report he could give us from the website dashboard on which providers are reporting patient no-show data. Does that sound
That is
familiar?
correct.
Ah,
Yes.
there you are, Justin. Hi.
Hello. So we had asked for that report. We got it back. It wasn't exactly what we wanted. So we've clarified our report request. And what we're going to get back is each provider type and the percentage of providers in that provider type that are actually putting data in the portal. So that's
That's
the,
what we want. Yeah.
yep, that's the request that we've put in now. We've clarified that. So we'll, as soon as we get that, I'll send that to Aaron to distribute to TAC members.
Okay, thank you. Because one of the things, and we got this a long time ago when this first started, we used to get that report because we were concerned that there were not a lot of behavioral health providers that were reporting. So that's what we're really looking for, Justin. So thank you. If you could send that to Aaron, we will get that out to folks. That's great. Leslie, this is probably you, the changes in the delivery of mobile crisis services.
Yes, of course, there's some things I'm still not talking about, but I can share several things with you today. So I thought I would give you that information. Provider letter was drafted on January the 3rd, and we have got the draft approved, and it has moved on through the process for distribution. I expect that letter to come out probably early next week, maybe, if not sooner. I don't think it's going out tomorrow, but there is still a chance. Once it's been distributed, then we'll post onto our website, and then we can have more discussions if that's okay. The other thing I wanted to share with you is if you've heard me speak before about the mobile crisis continuum in the past, you're aware that there's two models. We have a Commonwealth model and a community crisis co-response model, which I know you guys love acronyms, but it's a CCCR model. Governor Beshear publicly announced today, or previously, that the grant opportunity was out there for municipalities a couple months ago. And he also announced today on his updates that 7 awardees on the 1230 updates that he does, the Team Kentucky updates. Those awardees are Boyle County Fiscal Court, Christian County Fiscal Court, Cynthiana Police Department, Lexington Fayette Urban County Government, Maysville Police, Perry County Ambulance Authority, and Warren County Sheriff's Office. The awardees will establish corresponding units, which we will call CRUs, crisis response units, and partner with behavioral health professionals and resources with their first responder and or law enforcement. And this is to, of course, reduce the distress of individuals in crisis and to avoid unnecessary hospitalizations. I do want to mention that, you know, we've got these two models here in rural Kentucky because we wanted to, first of all, limit unnecessary law enforcement involvement that may result in a higher level of care that the individual might need, or incarceration or a psychiatric facility when that's not exactly what the member was needing. We want to make sure that we address the member's specific need that's in crisis. You've heard me say a call for an elderly person in crisis with dementia is not the same call as a youth with anxiety and depression. So we want to make sure that we can handle all those. So we've got the Commonwealth model, which minimizes the law enforcement, but we also realize, Dr. Schuster, and you've heard me say this, we are a very rural state. We need to build provider capacity and access. If you all are not aware, out of the 120 counties here in Kentucky, 112 are deemed by the federal government to be rural. So we want to make sure that we have an abundance of availability to handle our crisis situations here in Kentucky. And this will also help us to assist the law enforcement with providing behavioral health resources, training, some oversight with the grant opportunity. So we're very excited. I think we made history today. I don't know of any other state that has provided this type or level of mobile crisis continuum. And of course, we have worked with our sister agencies and a lot of agencies, even outside of our cabinet. The Department of Behavioral Health has been very involved and integrated with us. And I appreciate, again, I always say that all the integration and teamwork with making mobile crisis continuum finally coming to reality now. So I can tell you more later if that's okay, Dr. Schuster. The YouTube will be out there for Governor Beshear today. That includes the CCCR grant model awardees.
Yeah, I was just going to ask for clarification. So those 7 awards were made under the CCCR.
Yes, co-response.
Is that right?
So anybody that was connected to municipality, you had to have your municipality's support. So we had, some of them were fiscal courts trying to help out in their local areas. Some of them were police departments, Lexington, Fayette, Urban County government was involved. And then we have an ambulance authority that are also involved as well. So it was a good mixture across the state. So we're hoping that continues to grow. We will do another round of offers. If you all know of any folks that are interested, I've told the awardees, do not feel like your competition. We have enough crisis to go around, and we need valuable providers from all areas. So just wanted to let you know that we'll do one more round in the fall and then annually thereafter. So the grant opportunities go right now for 4 years.
Ah, okay. And what kind of amounts are all the grants the same?
Depends on what
depended
on what they ask for.
Okay.
So, and again, I can share more of that later. It's okay for me to share what I'm telling you now because it was made public at 12:30.
Okay. All right. So it's on the move. We've been
It
waiting.
is very exciting.
We've been waiting for something tangible.
Yes.
Yeah.
And you've heard me, Dr. Schuster, talk about this. Mobile is just one part of that whole sequential intercept mapping. All these pieces that we're adding right now is just, to help divert. And if folks do end up in incarceration or confinement, what can we do to help there and to ensure that they come out, ready to go with all the supports and services, medication, everything that they need to be successful. I'm telling everybody, will all this be perfect? No. Will we have growing pains? Of course. But, without trying to make all through progress, right? That's just happens through progress. So.
Yeah. All right. Well, I appreciate that update. Any questions for Leslie on this? She still is limited in what she can tell us, but we've gotten more info today. Okay, thank you. And as always, we ask for status on the Medicaid unwinding and recertifications. Is that you, Veronica? Maybe not.
Veronica, you're muted.
I know, I'm having trouble today. Yes, it is. I'm going to share my screen.
Right.
And we always provide this afterwards, so I won't. I'll try to be somewhat quick in my. Just 1 second. Okay.
Well, we appreciate the detail, Veronica, very much, and we will get that out to folks for sure. So, and I see that Commissioner Marks has joined us. Welcome, Commissioner Marks. We're very glad to have you.
Thank you. I apologize for being late.
That's no problem. We have a long agenda, so you could come at any point in the meeting and we're probably still meeting. So.
Okay, so just I always stop on flexibilities. We don't have any new ones. The last ones we reported, I think, were pretty significant and helpful to our members. That included suspending all child renewals. So any child with a renewal starting in October, we went ahead and granted 12-month continuous eligibility for those folks. They were not going to have to go through a renewal. We redistributed December renewals, but just a reminder, that doesn't mean that we didn't have renewals in December. We still maintain December renewals if the renewal was aligned with another program, so SNAP or TANF. The reason for that is because then the eligibility worker only has to touch the case once and can make the determination based on the income for all those programs. So we left those renewals in December. If a member had exhausted all of their extensions, so if you recall, we have a 1-month extension for all members. If they don't respond to a notice by their renewal date, we extend that for another month. And then up to a 3-month extension for any member who is a long-term care or 1915C waiver member. So each month that we don't get their response, we're able to extend them, and they can go to a max of 3 months. So if that extension exhausted at the end of December, we're not permitted to continue to extend them or to redistribute them. So we did have to go ahead and terminate if they didn't respond. So you'll see December approvals and terminations still for those very limited reasons. So moving on, always just reminding folks that, and the commissioner mentioned at the top of the meeting that we did amend all 6 1915C waivers, home and community-based waivers, so that we could maintain those flexibilities beyond the original termination date of November 11th. So the increased rates and all the other flexibilities are incorporated into those waivers and are extended as a result until that waiver is approved by CMS. We have no idea when that'll happen. They, we weren't the only state to do that, so they've been inundated with all those amendments, but we'll continue to keep folks updated on that. So yes, we have seen a drop in Medicaid enrollment, but as the commissioner mentioned, we're still, over 200,000 and when we started the PHE. So we still have a lot of folks covered and we still have a lot of folks going through renewal. But so you can see the kind of decline here that has happened as a result of renewals and terminations. Again, a reminder, terminations might be due to the fact that the person's no longer eligible, so their income exceeds the Medicaid limit. And we did see that, over the course of the public health emergency. Our system still went out and checked income. And so we did know that there were folks no longer eligible for that reason, or their category of eligibility changed. So for example, if they were in foster care, that grants them Medicaid eligibility. If they had a change in that foster care coverage, then when their renewal was up, then they would have to be determined eligible under another type of assistance. So we'll see, folks continue to drop off for those reasons. So here's a snapshot. We have through December. So we are, this is kind of hot off the press for our December numbers. You see it's a lower number of total individuals. It's this 30,705 because we would just redistributed a fairly large number across the rest of the unwinding period. But because of that, we have a really great approval number for and rate for December. So 28,889, which is great, and only 1,244 terminations. We still have 2 pending from December, and we did extend 570. Those are the ones that are in the bucket of they didn't respond to a notice or so we're going to continue to extend them. Looking at November, because I don't know if I had these numbers when we met last, but just again, November was a little smaller too, because we were implementing some of those flexibilities, including moving the children. So that was over 400,000 children that got moved. So that has reduced the number of renewals. And again, fairly high number for approval for November, 22,888. And a lower number of terminations for November, 1,508. And then, of course, the extension bucket, you'll see can be large depending on the month and how many people were continuing to extend until they're exhausted. I want to note that these are based off of the CMS monthly report that we're required to file with CMS by the 8th of the month for the previous month's renewal activities. Those are posted on our website, so anybody can go out there and pull that. We did just complete December's, and so that'll be up shortly if it's not on there already. I wanted to note that because there's something else that has happened and changed since the last time we spoke, and that is CMS has asked states to update their numbers in their monthly reports and to go back and do that retroactively. So what that means is they have asked states for every month to look at a 90-day snapshot following the month of renewal and report any pending actions. So we have just completed that. We were required to file by December 29th, the report for May, June, July, and August. And then the report for September will be due on January 15th. And then the rest of them will be due the 15th of the following month after the 90-day period. So for example, just to explain that, because I know that sounds confusing, for the month of May, they asked us to, and we reported right here, you can see 6,669, we reported as pending. What we've done is if we processed those pending renewals in that 90-day period, we then have to report to CMS what the outcome of those processes were. So people will be put into the bucket of approved or terminated as a result of that, and we'll completely update the report based on that. So those will again be posted very soon, and then we'll continually post those as we submit those to CMS.
So is that, Veronica, is that just CMS's way of saying, okay, if you've given everybody the 90-day period in which to reply, and so you can kind of close the case and they want to see what the final result is? Is that basically what they're asking for?
It is their attempt to supplement the information that's out there, because there isn't anything that talks about the pending cases. I appreciate that, but understand there will still be a gap, because if we can continue to pin the case, which means the person's covered, by the way, we can continue to pin the case longer than 90 days if we are trying to resolve, the documentation that's been provided, if we're trying to do additional outreach efforts for that individual and to be able to make a determination. So it helps provide some additional information, but there's still lots of activities going on that falls outside of the reports.
A lot of work for you all.
Yes.
Yeah. To go back to all those months and pick up on all of those cases, huh?
Yeah, they and to ask states to do it retroactively, we did not know this was going to be a reporting requirement when we started unwinding. So they have to go back, and some states actually were really struggling with that. Luckily, in our state, we had already been tracking them, and so could easily go back and pull them. But I think some states were having really a lot of trouble to do that. So just a reminder, we do have new demographic reports out, posted on our website that we started in September. I won't go into a lot of detail. Certainly encourage you to go out and pull those down. They actually tell you approvals and terminations at the county level. So you can take a look to see if you're interested in your county or a particular county, what's going on with approvals and terminations. And then of course, also at the gender, race, and ethnicity level. And just a reminder about the 90 days. So we still track if somebody does get in, if they get terminated and they come in within that 90 days after and are able to provide the information we need and are determined eligible, we'll reinstate them back to their termination date so that there's no gap. This is something that should be done automatically. The member doesn't even have to ask for it. So, you know, we also like to see this to make sure that we're reducing the number of these are folks that were going through an active renewal and didn't respond to a notice. So it's good to see, you know, people coming back in and continue to track those. And our outreach priorities really haven't changed. It's really just encouraging folks to respond. And even if they don't think they're eligible, we'd like to make that actual determination. The reinstating, you know, if somebody comes in to a provider's office and they're within that 90-day period, and they show that they're no longer eligible, to encourage them to get connected to someone who can help them provide that information and get determined eligible. And then we know folks aren't eligible, so we want to make sure they do get coverage. So connecting them to that qualified health plan on Connect, to go out and choose one to keep them covered. And just a reminder, we have lots and lots of educational and outreach materials on our website. Very much member focused, provider focused, stakeholder advocate focused, to try to help everyone communicate around renewals. A couple of new ones was a reinstatement. So when somebody walks in and they're in that 90-day period, this is really great information to share with them just to help them understand what they need to do next. And then this brand new one here, the last one on the right, is about ID proofing. And what that means is if a member wants to go out and create an account on Connect in the self-service portal so that they can communicate with Medicaid about their renewal or about their application. Some of them were having a hard time navigating the required identity proofing that has to happen with creating an account like that. So we've created this proofing tip to help folks understand how to navigate that, because there are very much ways to get around that if they're having trouble, if they're struggling with it. Also, I always wonder if there's a new provider on that I want to remind them that they can get access to their patient's redetermination date through 2 different portals. All providers have access to Kentucky Health Net, and so they can go on there and look for it. Or if you're a 1915C or long-term care waiver provider, it's in clocks and they can pull a report. That just helps them know and prepare, especially for our long-term care and 1915C waiver providers, to maybe help the member prepare what they need to have in order to go through that renewal. And then if you're having somebody come in to see you for a checkup or an office visit, checking that renewal date just to see if it's coming up or if they're currently in the renewal process is helpful. I always want to have a plug for Qualified Health Plan open enrollment. It's going on right now, goes through January 16th. However, make sure folks understand, if anybody loses Medicaid eligibility during the unwinding period, all the way through July 31st, at any time, they can go and choose a plan on the qualified, on Connect, a qualified health plan through an unwinding special enrollment period. It's just a checkbox that all you have to do is say, I lost my Medicaid eligibility during this period of time. And so that waives the open enrollment requirement and allows them to enroll. So we have seen, as a result of the Medicaid trending down, our qualified health plan enrollment trending up, which is what obviously we want to see. So if folks are determined ineligible or believe they're not no longer eligible, they're going out and taking advantage of choosing the plan. We always want to make sure people understand there are scams out there around choosing a qualified health plan. So just remember, the only ones that are there are 4 that are qualified to be on Connect, and that's Anthem Blue Cross Blue Shield, CareSource, Passport Health Plan by Molina, and Ambetter by WellCare of Kentucky. If some other company is calling them and saying, oh, you can choose me and you can get tax incentives, and it's not true. So just reminding folks, some things to look at as they navigate that. And then always a plug for our website, lots of information out there, the CMS reports, the flyers, and all of our stakeholder meetings are recorded and posted on there. Speaking of which, our next one is coming up on January 18th, the 3rd Thursday at 11 a.m. But if you can't come, check it out at your convenience at any time. And follow us on Facebook, Twitter, or Instagram, because it is the best way to stay up to date on what's happening in unwinding.
Wow, that's a lot of information. We'll look forward to getting the slides. That's great, Veronica. We appreciate that.
You're welcome.
Any questions for Veronica? I'm sure you all memorized all of this as you went along, and some of this is hot off the press with the December numbers and so forth. Kathy, you had a question, I think, about further diving into types of people that are losing coverage, or what was your question?
My question, and really the more we talk, the more, thinking about, ways you try to head this off. But my question had to do with the percent of people losing coverage. What percent of them are folks who just didn't respond? And what I'm thinking about is people who are, are seriously mentally ill, who, are pretty symptomatic, and they get their renewal notice, and it, they don't read it. It goes in the trash, or it gets, just thrown on a pile of stuff, which, it gets very specific in my mind. But the question was just more to, the broad issue of people not responding. There's the homeless population as well, falls in that category. Some of whom are seriously mentally ill, and some of whom are not, have other issues.
Sure. So of the terminations, about 50% are what we call the procedural terminations pretty much due to lack of responding. What we have a lot of outreach around this. So every time that somebody is up for renewal, about 90 days before they get a notice about 60 days before the renewal date. And then during the time where we actually send the notice to let them know they're going through renewal, and until the renewal date, about 2 or 3 other times they're hearing from the state, because we're calling them, we're texting them, we're emailing them. And then the MCOs are doing the same. But to your point, if somebody doesn't answer the call, doesn't open their mail, and doesn't read their email, they're not going to know. So what we've tried to do is also reach the member at their provider. So a lot of the MCOs are sharing lists with their primary care providers, and a lot of them are willing to be very proactive around this and reach out to the patient as well to make sure that they know what's going on. So we try to look for ways to find individuals where they are, and make sure they understand that there's some action that they need to take.
Right. But it also just kind of impresses upon me the need for as many people as possible out there to have somebody on their side, who's looking out for them, an advocate, a case manager, whatever it is, an outreach worker, somebody.
Absolutely.
Those who
Absolutely.
are more disabled, are going to miss a lot of the more formal methods of outreach.
Absolutely. We also, being concerned with medications and prescriptions, we've done some targeted outreach to pharmacies to make sure that if somebody comes in and it's showing that they're no longer eligible for Medicaid, what they can do to help that patient get connected to somebody who can help. So again, just trying to find the person where they are, or somebody that can help them.
Right, thanks.
Now, I know that Val has asked this question before, and I'm sure that the consumer-run organizations like Participation Station are trying to remind folks. But again, that means that people are engaged in that activity and are coming in, right, Val? So, you know, we have a lot of people that are not engaged in the consumer-run organizations either, but we're certainly trying to do that. And I would hope that the NAMI groups, I probably ought to, I've got the email addresses now from Jade Norris, who is the new NAMI Kentucky statewide. So I have the email addresses of the affiliates, and we probably need to send some of this information out, Veronica, to that group.
Yeah, if you'd like to share that with us, because we have met with various stakeholders, like the advocates and organizations that work with maternal health, those that work with child health, and tried to come up with specific outreach plans for those populations to try to reach them. So we'd be happy to reach out to her and you know, see is there something different we can do to help that community.
Yeah, and I think she was on earlier. I don't know if Jaden is still on or not, but I can I'll make an email introduction to the two of you because she can send stuff out, and I also have those email addresses. But that gets more directly to those local NAMI affiliates, you know, the big ones like Ellie is typically on this call from Lexington, but some of those smaller ones. Yeah. And we've sent this out. I know the comp care centers have gotten these and, you know, been encouraged to hang the posters and do that kind of thing. Because obviously it's in the provider's best interest to keep people enrolled as well, right? So it really is in everybody's best interest to keep people enrolled. So
working on it as well, Sheila, the CMHCs, we're trying to get people. Let them know what's happening, right?
Yeah.
Because Kathy Dobbins is right. Mail's not always responded to. People are leery of what they get, so.
Yeah. So we'll continue to beat on that drum as well. But I'll connect you with NAMI Kentucky. Veronica, thank you for
That'd be
this.
great. Thank you all.
Yeah.
Hi, Sheila. I wanted to say I am on.
Oh,
and
there she is.
yes,
Great.
thank you. Just make that email introduction and we can move forward.
Yeah, great. We'll do that. So you all can see each other. You're side by side in my little setup here. So I will make that introduction. Great, Jaden. Thank you for coming on. Let's see. We had a good discussion last time, and again, Justin was very helpful, Justin Derringer, about the Medicaid billing for mental health services to students from schools. And I guess my follow-up question, Justin, because I don't think we had enough time last time, is some of that billing, and I think Karen Garrity was on and brought this up from Life Skills. Some of that billing is being done actually by the contracted provider, right? The CMHC. So
Yes,
I'm still trying to figure out, we're trying to get a handle on how much Medicaid billing is going on from the schools. So we've got to look at what the schools are billing, but we also, I think, have to look at what contracted providers, most of whom I think are going to be CMHCs, but they may also be. So is there a way to track that from the place of service?
Yes, ma'am. So there's a survey. We are working on a survey that's going to come out later this month. It's a survey that the Lieutenant Governor's Office, the Kentucky Department of Education, and DMS have worked on. Erica Jones, who's the branch manager of our Child and Maternal Health branch, has been working on in those meetings and working with this survey. It's going out this month to districts, and it has a variety of information in the survey, but it will allow us to track exactly how each district bills, whether they contract with an entity, whether they bill it themselves, what entity they contract with, and that will allow us to pull from all those different provider types and pull those place of service codes and be able to put together a comprehensive look at all the different billing for behavioral health services.
That's music to my ears, and it will be music to Dr. Barzione's ears too. He's the retired school psychologist that was on last time. He's out of town today, but he had raised that question because we've presented to the, as did Steve Shannon, to the interim task force on school and campus security, which is really about behavioral health services in the schools. And this question has come up. And actually, Representative Lisa Wilner has filed House Bill 36. And one of the issues for KDE is to actually track exactly what we talked about, Justin. So this is really very positive. I appreciate that. Is it possible for you to send me a copy of the survey? Just
Absolutely. Yep. As soon as we get that back.
Okay, wonderful. Thank you. That's very exciting. And we will be looking for some follow-up from you. You would just let me know when you're ready to make, some kind of report to us about what you found out.
Sure, absolutely. I'll get you a copy of the survey, and then as soon as we get the results back and quantify those, we'll present those.
Wonderful. We're making such progress on these things. I love it. So next item, in case you all haven't heard, the legislature's in session. They always say batten down the hatches in Frankfurt when the legislature's in session. So we've had 1 week of, it was pretty quiet the first week. It's certainly picked up steam. Obviously, the biggest issue is the budget. And we're waiting. We have not seen the House budget. The governor released his budget. And Steve, I forgot to write down, what's the bill number for that? Do you remember? I think
it's 114.
House Bill 114. Thank you. So if you want to see in bill form what the governor recommended, Representative Derek Graham, on behalf of the Democrats in the House, has filed the governor's budget bill. But we are waiting, and we've heard that it's going to still be released this week. But unless it gets released today, my guess is it's not going to be released until next week, what the House budget is. So some of the things that I think we're looking for in the House budget, funding for 988 for the call centers is a huge issue. And we want to be sure that that's on there. We want to be sure that the comp care centers have their pension liability supplement in there for sure. There's been some talk, although it's not in House Bill 36, which is a mental health in the schools bill that I mentioned. Lisa Wilner and Bobby McCool is the primary co-sponsor. There's no budget request, but I have talked with Senator Max Wise, who's always been the leader of the school safety and resiliency legislation in the past, and he thinks that there's going to be some funding around school mental health. So we certainly are going to be looking for that. We're hoping to get funding to have a nurse, a full-time nurse in every school building in the public school system. We think the nurse is a vital part, not only on the physical health side, but as you all can imagine, on the mental health side. When I testified to the task force, I said, as much as I would like to think that if a student had a problem, that they would feel okay about raising their hand and saying, I need to go talk to the school psychologist, it seems very unlikely that that is going to happen in a classroom. Right. But they are quite possibly going to raise their hand and say, my stomach's hurting, I need to go talk to the school nurse. And so the school nurse becomes kind of the central referral point in a way, and also has a chance to talk with kids when they come in and, becomes kind of that trusted adult. So we're hoping to get that done as well. Some other issues that have come up. Mary's had to get off, but there's a big campaign to try to get the waiting list on the 1915 C waivers. That's the home and community-based waiver, the Michelle P. and the supports for community living SCL waiver. There's about 12,000 people on those waiting lists. And so Senator Whitney Westerfield has a fascinating bill, Senate Bill 34. He calls it his Momnibus bill. He worked with a bunches of people to say, what does every new mother and new infant in this Commonwealth need? So not only the immediate kind of childcare and maternal health kinds of things, but all those social determinants of health. What are the barriers to food security? What are the barriers to adequate housing? What are the barriers to education? Every piece of that. So I made the argument with him that I think without abortion being available, and we hear this actually from the National Association for Obstetrics and Gynecology, that we're going to have more children with disabilities born in this state. And so we're going to need more waivers eventually for services for kids who have developmental intellectual disabilities and other kinds of disabilities. So if you look at Senate Bill 34, the funding, the first 2 years of funding on Steve's formula for getting rid of the wait list is in there in the back sections of that bill. So it's pretty exciting. The other bill that's been discussed in the interim, and it's something that the Mental Health Coalition has followed and supported for some time, is the CAR bill, the Crisis Aversion Rights Retention. It's Whitney Austin, who was shot 12 times as an employee of Fifth Third Bank back in 2018. And this was previously a Paul Hornback and Morgan McGarvey. It's always been a bipartisan bill. This year, it's Whitney Westerfield and David Yates. That's probably going to be filed by the end of January. It is not actually a red flag law. It takes a little bit different perspective. And we've worked with Whitney to make sure that there's not an overemphasis on mental illness, because we know that folks with mental illness are 10 times more likely to be the victims of violence and to be the perpetrators. And our concern about some of these red flag laws is that they assume that the person is mentally ill, and we just don't feel that's the case. It's also a great suicide prevention to have a way for the police to temporarily remove firearms from someone who is in crisis. And that's the language they use, is someone.
And it really reduces access to firearms, which is what the bill
really
wants to do.
reduces access at a time of crisis. It also, and Steve and I have talked about this, many of you know who are mental health providers, that there's been a duty to warn provision as part of KRS 202 for 20, 30 years, early 1990s. And what's been reported to me by therapists who have reported someone to the police is that the police say, okay, but I can't do anything about it. I mean, unless they've committed an act, I have no authority to go and do anything. And actually, the CAR bill would be the perfect mechanism for police to take that case to the judge and get an immediate ruling that would allow them to temporarily remove the firearm. So that's a bill for you all to be aware of. There are, unfortunately, as always, some negative bills. Senator Wilson and I don't remember the number now, it has a bill to prohibit the universities from doing anything that involves diversity, equity, and inclusion. They're anti-DEI bills. That's now become the new woke agenda, I guess, the new rallying cry against everything that people are trying to do. So anything that would classify people or put people at odds with each other and so forth. But unfortunately, Senator Meredith has now filed Senate Bill 93 that applies that to the public school system. So there would be an absolute prohibition against anything that we might think of as diversity, equity, and inclusion. And he also removes the language from the school safety and resiliency bill that talks about trauma-informed schools. And I don't know how trauma-informed got in there, but somehow somebody must have told him that that was some classification system. So there's going to be a number of things for us to be concerned about.
And Sheila, I think House Bill 5, right?
Yes, House Bill 5 is has a small piece in it that makes a change in KRS 202C, which some of you may remember was added a couple of years ago, and it addresses those folks that have committed a felony offense or been accused of committing a felony offense, but are found consistently incompetent to stand trial. And there have been these folks that keep rotating in and out, and there was no way to hold these folks at KCPC or any place else. They're not eligible for involuntary commitment for any length of time. So we put that piece in, and it did solve a problem of a person in Jefferson County who told people he was going to hurt somebody if they let him out, and they had to let him out. And he raped a 7-year-old and hit her over the head with a shovel, creating a traumatic brain injury. It's really an egregious case. And so he's out at KCPC. But there was a recent case of someone who murdered his mother, who was severely mentally ill, found incompetent, but didn't meet the criteria because he didn't have a previous even conviction or history of violent offenses. He had never had another offense on his record. So there is a change in that in the bill. The rest of that bill, which is called the Safer Kentucky Act, and it came out of the Jefferson County Republican caucus, has a lot of things in it that people are opposed to. Would criminalize almost every kind of temporary housing. Sleeping homeless person would have, they can't sleep in their car. They can't sleep on public ground. There are, it also does a 3 strikes and out, where people are almost put away for life after 3 violent offenses. Increases the punishment for almost every class, I think, Steve, of felony.
I think so.
You know, threatening to kill a police officer suddenly has become, you know, incarceration for life almost. So there are lots and lots of groups, including the ACLU and a lot of the racial justice groups that are working against it. So this little fix on 202C is gonna, we were hoping that would be handled separately than being put in this bill. But that's House Bill 5, and you all may want to take a look at it if you're.
And even that fix on 202C could expand that to many, many people.
That's right.
Yes. Yeah.
And also in there is a prohibition for federal and local funds to go towards Housing First, which has been identified as a, you know, we all know is an evidence-based practice, and HUD requires or prioritizes Housing First, gives extra points to communities that use Housing First. There's even some concern that state agencies like the Kentucky Housing Corporation, which takes care of the balance of state funding for the HUD homeless grants, would not be able to do that because they are because of their source of funding, that they would lose their ability to contract with organizations that are taking that approach, which HUD is prioritizing. So it's really distressing.
Yeah, there's lots in there. I don't know why they've gone after the housing first, Kathy. I don't understand that. I mean,
Well, it's a national initiative. I think it's I believe it's called the Cicero Institute.
uh,
And I actually looked at that, and I'll send that to you, Sheila.
okay.
They actually have like templates that they provide to states across the country.
Wow.
So, and some of the language is cut and paste word seems to be.
Yeah, we get a lot of that, I think, on some of these things. Kelly, you had your hand raised.
They're actually referring to Housing First programming as a complete dismal failure, which all of us who work in evidence-based practice know that's not even true. So, you know, who filed the bill, Sheila? I can't even remember right now.
I think it's
Bowman?
Representative Bowman, right? Baumann.
Yes, that is who I saw speaking about this factless statement of Housing First being absolutely a dismal failure everywhere it's been tried. I can certainly say that here in Fayette County, where the Hope Center administers that program and New Beginnings, it is not a dismal failure.
Yeah.
I think the success rate in Jefferson County, Metro Louisville for those HUD homeless grants is at 98% maintain housing after a year.
Yeah.
Yeah. So, I mean, it's obviously working.
Yeah. And I think that probably every Republican from Jefferson County has signed on as a co-sponsor, because the original press conference was Jason Nemes and Kevin Bratcher and Ken Fleming and all of those Republicans. So this has been out there. There, as I say, there are lots of groups, but the fact that it was given that house number, you know, typically the lower house numbers, the single digit House and Senate numbers are priority.
Yes.
So the fact that it was given a House Bill 5 number is really disarming and disappointing.
Yeah. And the state stands to lose a lot of money and to go towards housing people who are homeless and have really great needs. And, you know, we're talking about the problem of homelessness, and then we're taking away the solutions. I mean, it makes no sense.
At a time when we're at an apex of need, you know,
totally. 100%.
Absolutely off the charts, the need right now for housing for our folks. And if this were to happen, I'm like you, Kathy, I just can't even I can hardly imagine it. But I know that here in Lexington, we're joining forces with all of our shelter providers like Catholic Action and Jenny Ramsey and people like that who are very outspoken on this issue. So I'm sure there will be a lot left to say about this.
Yeah, and I'll be making the bill grid for the Mental Health Coalition and be happy to share it with the TAC as well for those bills. And we'll be having a Zoom meeting mid-February, but we'll be sending out some action alerts as well. The only good news I can leave you with is that we're not West Virginia, because I just got an email from Brenda Rosen at NASW that West Virginia has filed a bill that requires mental health providers to provide conversion therapy. It is a mandate to provide conversion therapy, which is, as most of you know, is disregarded, bad news, causes kids that are LGBT to be suicidal, uses shame and all kinds of things to convince them that they are not gay, that they've disgraced themselves before God. I mean, there's just a horrendous amount. The other part of this bill apparently is that no trans person can be within 1,500 feet of a school. Now, how you would even regulate that, I don't know, but what it really means is that no one in West Virginia could ever be public about being trans, and certainly could not be associated, whether you're a parent or a kid or a teacher or, I mean, it's just outrageous. So just when we think they can't come up with anything that's worse than Senate Bill 150, there's apparently worse stuff out there. And that probably came from some national think tank as well, Kathy. I mean, it's one of these family foundation kinds of things or something, so.
Yeah, and Sheila, real quick, House Bill 5 has 44 co-sponsors.
Yeah.
44, wow.
That's 45 plus the sponsor.
Yeah, so almost half of the House have signed on as co-sponsors.
And more than half of the Republican caucus.
Wow. Well, if you click on that link I put in the chat for the Cicero Institute, they have something called a new way on homelessness. Number one, states should ban unauthorized street camping. 2, direct funds away from expensive, ineffective housing first programs. Pay nonprofits for performance, not just services, which I don't know where that comes from because I think all the nonprofits, at least in the continuum of care, have to provide outcomes. Anyway, it's all right there, most or a good bit of it.
Yeah. Well, we've kept you all over time. Let me just very quickly, do we have any recommendations for the MAC from the voting members? Anything? I don't know that there's been anything we've discussed that we're ready to make a recommendation on. We have several items for the March meeting, and in particular, the rate study, which I think we all will be looking for with bated breath. Under new business, Aaron just sent me an update from Medicaid on an MCO provider complaint form and some information about that. So I will send that out to you all. And apparently there is a way for you to report to Medicaid problems that you're having with a particular MCO. So I will get that out to you. I had not seen something like that before.
Sheila, the whole TAC should have received it already.
Oh, I'm sorry. Great.
No worries.
Thank you.
I
very
have a
much.
big group for all the Macs and TACs that I share with that.
All right. Leslie, if you're still on, you were going to look into the TCM policy clarification. I think it had come up with Adanta still.
Sheila, this is Leslie. I think I ended up, so the last thing that I had with Adanta, without sharing too much information on the call, is that they were waiting for their last letter, and I did reach out and ask for that letter to be sent to them. So I think they have it now. Tracy?
I don't know if Tracy's on or Karen Lenz. Anybody on from Adanta? I'll check with her.
Sheila, it's Karen.
Yeah.
I'm on.
Oh, okay.
Hi, I think that they did get something from them, but it still talked about recoupments in it. So Leslie, check. I think you got an email, and the last I saw, you were gonna check into that. But we can resend that to Leslie. But I don't think that it is that it's buttoned up.
So she did get they did get the last letter. Is that correct?
They got the letter, but the way the letter was written, it talked about recoupments. Like they were still going to go after some money over their interpretation of the TMC.
Okay, I won't
I'll ask
here. Yeah, to send it to me.
Yeah, I'll ask Tracy to get back in touch.
Okay.
Thank you. And
Okay.
Sheila, thanks for raising it.
Yeah, we'll keep it on until we get some resolution, because I think it still is of concern to other providers. And any formulary issues from anyone, not just voting members, but anybody in the meeting. No news is good news, folks. Next MAC meeting is 2 weeks from today. And remember, we start at 9:30 and we're going to end absolutely at 12:30. You all are invited. And our next BH TAC meeting is in 2 months, March 14th, again from 2 to 4. So I thank you all. We had a
I think Kelly has a question, Sheila.
Oh, I'm sorry, Kelly.
That's okay. I'm sorry. I know we're over time, but I do have a question about whether or not workman's comp can deny paying for trauma-informed mental health care for someone who was the victim of a shooting. They were a bouncer at a club in Lexington and protected a whole club of people by overcoming the gunman when he drew a gun in the bar, and he was shot with life-threatening injuries, and now workman's comp is denying him trauma care.
Huh.
So I don't know where to go to ask the question. That's certainly not parity.
So that's not a Medicaid question.
I know.
I don't think any
know.
of us could help you with that.
I know it wasn't, but I'm concerned about where to go for the insurance aspect of it, because he doesn't have Medicaid or anything.
So how do we contact workers' comp? I guess is the question. I don't know the answer to that.
Yeah, it may not be for this committee at all. So I'm just worried about this individual. But Sheila, maybe you mute. Yes.
Kelly, let us take that back and we'll email you with a recommended contact for you.
Yeah, I've been contacted by the mayor's office and also his father.
Okay, because it actually may be Department of Insurance, but let me figure that out. Okay.
Thank you so much, Veronica.
That would be great, Veronica. Thank you.
Thank you guys so much. You're so wonderful.
You're welcome.
Okay. All right. Happy New Year to you all. Thank you for your patience and your advocacy and your help for everyone who needs behavioral health care. And I will see you in, maybe I'll see you in 2 weeks. And if not, I'll see you in 2 months. Thank you all. Bye.
See y'all.